Thank you very much, everybody. Responses to thank you for that. Always the biggest challenge in the afternoon is to get back to actually focus. Just want to, I'm conscious that Rachel on the time press. Rachel wants to be presenting the Shropshire Data Partnership Chair report. Not with us. Again, anything you wish to highlight or we try attention?
Yeah, I think it's just a couple of things that we have to report there and all kind of because we focus on the throughout today. There's a couple of really important things around place-based working and positive news story around 2 hours of funding that we're getting into Shropshire. One was the prevention funding that Ships and Children received, which will allow us to move forward to the prevention work we want to do. There's 28 bids that we received against prevention funding, and the 603 that we needed to build capacity to support native working, particularly the voluntary sector. Issue that we have resources. So it should be already a really small money would be allocated to that. But I think there will be a question to do more if you think about absolutely part in a wide terms of the poverty issue of this, how we manage that. So there's a lot around building capacity. There's a big group prevention in people's health. Again, some of that many discussions and the statement around frailty actually, not to this around frailty and obviously this is also so should we going through a piece of work as 3 times the amount we've got available to bid for, so will be a bit of work to refine that, but I think it's really important because this allows us to build capacity to do the neighbourhood work, to do the joint work, and have that support. So that will come back to the next into the next shift where some decisions will be made. The other important piece that won't come back to shift because there's some funding from Energize, which again is about place-based work and building capacity around exercise and activity. And so there's been a subgroup that's been set up that will be using how will we use that funding. Again, I think top previously this is some funding we've been granted. And again, it's trying to dovetail all these bits of work to make sure we get the maximum benefit. That is likely to focus on planning and how we maximise some of the work that goes into planning to make sure that we're getting maximum benefit for our the waste units. I can think about it, like all of that so there's wide determinants. Some of the work we want to do around what would be known as safe memory or absences, actually was compensation that needs to have I just wanted to highlight all the bits of work to show how we can just tailor all of this and make it still we'll talk about to get back into our communities and still for the services.
Really helpful in terms of lots of progress being made. Any questions anyone wishes to highlight? As we asked, is our note this report also to approve the updated terms? So approve the updated terms reference, which will be appended. Thank you. I'll come on to Telford, David.
Thank you, Chair. I guess related to it, the council meeting in July, we have the excitement of doing targeted area inspection at game time. Only we've been for about 16 years, so we'd like to help. Joking part of the reason I'm referencing that is that the outcome is really strong, and the reference to that is really important. The lead inspector is Ofsted, and then we have CQC for health and HMIC for police. Basically not trying the table to the people that were involved. It was an interesting inspection, but it went really well, so I'll just mention that in obviously being here. The board are asked to note the recommendations in 1.2.1 and it references the National Neighbourhood Health Implementation Programme and the expression of interest, although disappointed that Telford didn't secure that work with no funding and extra work. That's not on me either. Delighted Shropshire have. It's interesting that the main factor of that allocation was predominantly based around destination, which we find interesting. And then if you widen that comment and you look at our cluster, in terms of declaration, and I know it all too well in terms of people working there and so forth, then they also did secure anything either. So a bit lost with some of that, but I know through Simon and his team we'll be looking for feedback as to why. And then under 1.4.2, referencing really what Rachel referred to as well, delighted that through the ICB we secured some prevention funding of just over 300,000, again oversubscribed, but allocated to some of those areas at the top of page 102, and delighted to be doing this work. It's exactly what place-based approach should be doing, and thanks to the team for allocating that funding. And interestingly, I was at a conference last week with a number of peers, chief executives across the country, and the place-based boards and approaches everywhere. In fact, it's quite limited in lots of places. So we're sharing the good work that's going on here, and I think that'll be taken by a number of the areas that the chief executive was speaking to as well. So it's the right thing to do. The concept of the place is everything. Thank you, Chair.
Thank you. And I think just to re-emphasise the commitment that we have to place-based work in neighbourhoods, because that's where the rubber hits the road and where we're going to see the biggest impact, and making sure that despite the change that's taking place, and I mean, I think there is, to think about clustering, there is a potential that we could then tick the eye off all of it. I think it's really important that we all are focused on maintaining the approach around neighbourhoods and place-based activity, because that gets both the best impact for our population. Any questions, David? Which we make report through the recommendations. Thank you very much. Moving on, we have I believe the technology is now evolved, so we are going to have that short video in relation to the care transfer hub in Telford and Wrekin. Hopefully,
the volume is at maximum and it sounds slightly quiet, but it's working.
My name's Kirsty and I'm the clinical lead for the Care Transfer Hub that work within the Shrewsbury and Telford Hospital. We have a team of nurses, allied health professionals, which are occupational therapists, physiotherapists, support workers and social workers. Our aim is to send home as many patients as we can with either a package of care or other support in the community through our district nursing service, virtual ward service, or even getting therapy to come and assess you at home for any further needs that you might have. Throughout this video, we're going to take you on the patient journey from assessment to discharge and how the team in the Care Transfer Hub will facilitate this discharge of you home.
We aim to discharge patients using the Home First approach.
The daily multidisciplinary ward meeting will discuss your estimated discharge date, discharge planning and referral to the Care Transfer Hub if needed.
For those requiring further evaluation on admission, our therapy team conducts a thorough therapy assessment to ensure that the discharge is done timely, safely and with the right support in place. Our team can refer onward to therapy services, deliver equipment to ensure your discharge is safe and in timely manner.
The doctors have said this morning that you're medically fit for discharge, you're ready to go home. Yes. I bet you're excited. I am so excited. Good.
I'm a social worker working in the Care Transfer Hub with nurses and therapists. At your discharge, we will support you to get a package of care which identifies your current care needs, and we will follow you at home to see how you're recovering.
We want to make sure that you're fully aware of what's happening throughout every step of the process.
I know that you met with my colleague Ria to discuss getting some carers in for you to go home.
Yes, I did.
Brilliant. Well, we sent your assessment off to the social work team, and I'm pleased to tell you that we've got the carers in place and they can start today at 5 o'clock.
Oh, it's wonderful news.
Yeah, happy about that?
Yes, I can go home.
Good.
Yes.
As a Care Transfer Hub, we will assess your needs from your point of hospital admission through to your discharge.
So if you are prescribed any new medication, the pharmacy team is responsible for making sure that we answer any questions that you might have with your medication, anything to look out for with the new meds that you're prescribed, and if you have any questions on discharge, we can make sure they're answered.
My name is Sarah. I'm one of the managers of the Care Transfer Hub team, committed to supporting our patients in hospital to be discharged at the right time, to the right place and with the right support required. We hope this video has given you an insight into the planning of hospital discharge for our patients and their journey home. Thank you for watching.
If we were able to see that, it does provide a very clear example, doesn't it, of the relatively straightforward process of bringing them together in a way that's going to be so impactful to A, support the patient in their we are guiding people. Great, thank you very much. We move on then back onto the agenda, onto system governance and performance and the integrated performance.
Thank you. Before I get into just a handful of highlights from the report, just to draw attention to the comment at the top of the executive summary. So we've touched a couple of times today on the government reform and the fact that there will be changes in the responsibilities of ICBs and NHS England over the coming months. And we're working through that with colleagues at NHS England at the moment, particularly around performance and movement. So what we just wanted to flag to board is that you might start to see some differences in what we bring here in terms of the critical information that we need as a board, and we'll be working with NHS England to make sure that we're sharing all of those relevant elements with them as well. The report itself is currently drafted in the same way as we've always done, so we try and highlight areas of improvement, which you'll see from the exec summary are growing, which is great and kind of mirrors and maps some of the conversations that we've had today. We also then flag any areas of concern, but again, as we've been talking through the agenda today, I've kind of been playing bingo on the report, thinking, yes, we talked about that, we talked about that. So I think just in more general terms, UEC, we mentioned, we still have some significant challenges there, but where we are seeing areas of improvement, they're starting to be sustained, and that's what we're aiming to achieve over time, which is reflective of the discussion earlier. One of the areas that we haven't touched on specifically today is our planned care, those elective targets that we have, and we are seeing significant improvements in some of our waiting times and movements on waiting lists. Still some work to go in certain areas, we can't be complacent, but we can see the impact of the actions that we're taking. I think just also to flag in areas of concern, trying to pick out some of those areas that perhaps we don't talk about more broadly on the agenda, but certainly we recognise that dental activity has now fallen behind target, and so our team have a plan to recover that. We should have time before the end of the year to be able to recover that. And also, as you read through the exec summary, there's other areas of concern that you'll see in the narrative. We are taking actions to address those where necessary. From a workforce point of view, the work that's been ongoing year to date and that will continue has been extensive. We see a very different picture to what we saw last year, and particularly we've seen some really positive efforts in staff again that are sustaining and driving a big difference. You'll note in the report that we flagged that bank staff costs are overspending quite significantly across the system, but when you look at that in the round, and particularly when you see the extent of vacancies that were coming in as substantive posts and the absolutely material reduction and sustained reduction in agency staff, it's overall a positive picture. But I know NHSE colleagues are looking to work with South and other colleagues to see what we can do around that bank position. From a finance point of view, and I touched on it very briefly in the AGM, but it's a positive position to date. We're maintaining delivery of the plan that we set. So in terms of delivering in year and doing what we said we'd do, we continue to be able to report that. We're not complacent. We know that it gets tougher in terms of the finance plan for the second half of the year. We've got some efficiency that naturally is backloaded because of the time taken to build and develop the programme, and we've talked a lot already about winter today and the impact that can have. but we've got really close scrutiny and oversight of the position and of the actions that are in place. So we're well placed to keep delivering in the way that we've described. We've also this month undertaken a series of risk reviews with each of the providers and with the ICB itself, particularly in terms of testing our confidence to deliver the outturn position for this year, but absolutely to make sure that we're not developing any material issues around our underlying position, because obviously our medium-term financial plan is already a challenging plan to deliver. So what we don't want to be doing is stacking up the current issues that will make delivery in next financial year even harder. Those reviews have been really successful. We deliberately invited clinical and operational colleagues. This wasn't a finance conversation, albeit it's been kind of driven by the finance team, because we wanted to understand actions and progress, not just numbers on a spreadsheet. And there'll be a deep dive at the System Finance Committee next week where we bring together the findings from those reviews, and we've got the opportunity with some non-exec colleagues to look at that and basically present the confidence levels that we've got in terms of delivery at that position. And just a quick note on capital, you'll see from the report that we're behind in terms of spending our capital money. We're not concerned about that at this point. There are good reasons why we're not quite in the plan that we had. And each of the providers and the ICB are working hard to make sure that we deliver that forecast outturn. You'll also see reference, which I think is really positive, that staff have managed to secure some additional funding for their laboratory information management system and EV charging points. So again, I just wanted to make that point that where partners are able to, we are seeking additional capital investment to support delivery of the programme as well. I'll pause there, have to people have any comments or questions.
And I guess the purpose of us receiving the performance report for the system overall is for our responsibility to commission that. Just really important to stress the responsibility for managing performance has to be the trust board, and the provider boards that I think would really emphasise that. I know that's known, but I think this would be my first week of chair to bring that for next year. However, there is then an opportunity for us coming together as a system to just reflect and see are there any particular pressure points in emergency care is clearly one of those, where we need to be asking for greater assurance, but also be thinking what might we need to do differently as a commissioner to facilitate that.
Yeah. Thank you. Perhaps I'm going to take a look at this book. So a year ago, I had a very difficult challenge because I was about elective care. These were significant, and I guess if I may just to say, we aren't complacent, but from a staff perspective, we've seen a 30% reduction in terms of the number of waiting for elective care. We've just achieved our best 18-week RTT for 4 years. In terms of the number of patients waiting over 52 weeks, we're now in the top performing trust in the country. We've been in the bottom decile for over a year. Cancer 28 days, faster diagnostic is now the best performance for the last 18 months. And we've come out of the bottom quartile. Cancer 62 day, we've just got our best performance in for over 3 years. And diagnostics for 6 weeks. We've improved now, and it's the best performance it's been in the top performing in the country. It's the best it's been all year. They are just numbers. And I think the other thing is, in terms of what we did recognise, is these are patients that were in chronic pain or that were off work, but also coming through our using pathway. So I guess thank you for indulging me, because 8,000 people are expecting me to, because at times these numbers get forgotten about.
Nice. That's what you just say in terms of the improvement of performance. Of course, it has a massive impact on patients and the confidence of the public of the NHS in a particular area. But also it's about staff morale as well. The staff will see really clearly that the traction and the energy and the passion that people put into recovery actually have an impact, and therefore you will just start to see that sort of permeate throughout the organisation. It's really important. Yes, acknowledging there are still challenges and still issues, but also the trajectory and the journey that organisations and individuals and teams have been on the same board.
And these are their family and their friends.
Just to welcome your opening remark. Primary responsibility. Whatever ICB clusters or our friends at NHS Midlands do or don't do, both my boards are really, really clear. The primary accountability performance rests with us. We will fulfil that responsibility. But there's still a long way to go, and I absolutely endorse all of those figures that I know Joe has. And we need to continue all of that. The prime area at the minute is clearly the urgent care, which you mentioned, but I just warmly welcome just to reassure you, we're absolutely safe. It's our job to be with other people's guidance, considering however you wish to do it, but we accept for both boards that's our job. Being improved.
As a commissioner, we will have theme, and we will want to think about how our commission intentions will reflect. Yeah. But that's a really important cultural approach. So I have these conversations that as things are changing and shifting, it's about the confidence in the board to deliver. That's really, really important.
You know, our job isn't to keep NHS. Our job is to keep our level of people.
Simon, anything you wish to add in terms of overall performance? No, I think. Any other points there, Mr. Roger?
Just a quick one. It's basically here. RJ&H have just closed their theatre for a while. It's not going to have a serious effect on people.
No, so from a Raj point of view, the first few months from April to June time were a challenge. Probably it was actually due more to their replacement of their electronic patient, which they have now worked through a number of issues, which is fairly common when you replace sort of fundamental systems in the hospital. I will say the performance is still low, but it's on plan, and they are on plan. They've been on plan in July and August, and they're proposing that they will remain on plan. And they have, I know, it's a shame to say it's not, but I know they have ambitions to go further than their operational plan. So as I sit here right now, both hospitals with elective responsibilities are doing very well, including Stockholm as well. They are achieving their plan and have ambitions to keep going.
I visited Robert Jones a month ago now, and a really good opportunity to have a conversation with colleagues around some of the challenges they have faced, but also a very clear, determined approach they took to bring about that recovery. And I had a good degree of assurance. I think it was sometimes being under the spotlight is not comfortable, and taking action to remove this stuff. But there will be no performance reports. Thank you. Really important report now in relation to NHS Recovery Support Programme transition.
Yeah, so again, we'll assume that paper is read and understood, but just want to just take you through a few areas in this chair. It's okay, with your permission. So, look, July 2021, the ICB was assessed at being segment 4 of the NHS's oversight framework as it was in place at that point. And being segment 4 was also mandated in terms of intensive support. So it was put in the recovery support programme, which is the highest form of oversight and scrutiny from NHS England. There were five main areas that were focused of that recovery support programme: finance, workforce, UEC, governance and leadership. Since 2021, the ICB has worked both to develop a system improvement plan that is system-based and is working provider colleagues in terms of developing that jointly, and then has also worked on its own improvement plan against the area where the ICB was identified as being most challenged. So as we've worked through 2021, we have reset our governance, we have refreshed the leadership approach, and we've continued to deliver against that transition criteria. As we sit here today, we've made significant progress on finance, workforce, governance and leadership. And as we've heard throughout the meeting, whilst progress has been made, we remain with a really challenged position across UEC. We've worked with NHSE, and they are really clear that at a regional level, they are supportive of the ICB now moving and transitioning from that highest level of oversight. The ICB's position, and I've been really clear with Chief Exec colleagues on this and with the exec team and the leadership team, that whilst we are absolutely supportive of this request and would ask for board support to continue to make the submission to move out of RSP and R4, the focus on UEC remains one that we need to remain committed to from a system perspective, because, as I said right at the start of this meeting, the only solutions we've got to UEC do not lie with individual organisations, individuals. They lie with our system partnership and our system response. So even if the ICB is successful, which we're hopeful that we would be, to move out of NOT4 and to move out of RSP, the commitment's really clear in terms of that UEC agenda and the importance of navigating winter, irrespective of that oversight piece. So actually the focus is much more on quality, safety, and delivering that improvement plan as we've talked about. Having said that, equally, I do want to recognise the work and the progress that colleagues have put in to lead this. We touched on in the AGM some of the governance piece and the leadership bits, the change in staff survey, the refresh leadership team, and the way and our operating model and the way it's operated and worked, which has been recognised by NHS England as part of their oversight piece with us. We've got a clear transition plan should we be successful in receiving national approval in terms of this, and a really clear timeline in terms of how we make sure that we don't lose sight of the work that's been continues to happen and has taken place so far. But the paper does request board support to formally submit the proposal to NHSE that we exit from the recovery support.
So this is the next step in the journey.
It is the next step in the journey. Yes.
Comments or observations from anybody?
Sure.
It's just a thought process around clustering. Is there any likelihood that NHSE will consider potential impact of the extra work around clustering that might suggest that they will hold back for a bit longer until, or is it so cut and dry as well as an ICB currently? This is where we are, and we'll have to agree.
I mean, I would never assume that anything's so cut and dry. I would like that confidence. That space. However, the clustering is really clear that we're dealing with two statutory organisations, and each statutory organisation will be judged in its own merit in terms of where it's at that point. So on this situation, the clustering will not impact on that because it'll be where as STW we've got to, and it'll be assessed against the criteria on that basis.
Thank you. Yeah, that's well done. And I think we really need to acknowledge all the work that's gone to get this basically before. We've been on the water step, we're still feeling like we've had a start. I think the recovery, there are two things I wanted to say. The recovery support program has been a double-edged sword. The relaxing marginally possibly of that oversight, no more of those that might be linked in this region with people coming that sort of thing. Will I'm sure will be great, but there are some resources associated with it as well. And do we have the sort of capacity and resource to replace what we might lose there? And then again, I know the answer to this, but really for assurance from board point of view is that we don't take our foot off the pedal. Everybody's put a huge amount of thought to get into this point, and it would be quite easy to go, we've got to keep that rigor process going to make sure that we don't.
So I think there's three important points in there. So firstly, appreciate the thanks in terms of the work, and you were part of that, everyone, in terms of starting that. So appreciate the efforts in terms of that. Secondly, I agree about the RSP support piece, but this year we brought a focus to saying that the ICB hasn't requested any RSP support. It said the focus should be with staff colleagues, but we do that jointly when they have commitments in that space. So we've already made a decision to step away from any reliance on that funding as we've managed that piece. I think the bigger challenge in that is much more the reduction that's coming as part of the clustering work and the NHS reset bit rather than the RSP bit. But we've taken that in from our side into a business as usual piece and work our restructure that was completed got us to a point where we were really clear what our focus was in the operating model and how we were working in that space. And then I think your final point in terms of not taking a breath, I think the important bit of the discipline has been our refreshed governance and the way that we choose to work has allowed us then to say this has become our pattern of work that we've now got into. So, and we had to demonstrate that to NHS England as part of the assurance process, but it wouldn't just be somebody said, yes, now you move from that. We now take a breath and sit down and do anything else.
Yeah, thank you, Simon. And you raised the really important discussion because where we start the meeting off in terms of and in terms of the fortnightly meeting, I think the point is now we can't get NHS England don't want to leave the room because they're excited about what we're doing. So we kind of some paper does leave you kind of thinking to what's next. And obviously there's somebody still left in Oxford, which is bad.
Yeah.
And it has been in there since 2018. It is on track to come out. We said to the end of March, we could look to it earlier, but what we said is that March, we would look to remove the undertaking and also to execute it. I can categorically tell you there is no resting on this at all. It would be significant for the system, it would be significant for staff. It is reliant on your meeting, which is why it's an important distinction and also delivering our financial.
So I enjoyed this conversation earlier about with the ICB removing itself from not being removed from RSP as a catalyst, and I think it's really important to have that maintain the momentum. Absolutely, this is about all parts of the system that being in a position to come out of RSP.
But the two are linked, and we should see them as linked. This is a process in terms of the ICB, but this is a process that's linked to then saying the next step has to be that SAF follows the same path and goes to that point as well. It's not a either or separate. This is a how do we do this in a connected region?
The other points? So based upon the evidence that the board has received, not only just in this meeting, but in previous meetings and the conversations that have taken place with NHS England, we are asked to support the requests for this proposal requesting full exit from the recovery support program. That agreed. Thank you very much. Moving on then to the LGR annual report.
Thank you very much. So this is the moving from the Light and Disability and Autism annual report. It's a statutory requirement, so I'm asking you for this to share with NHS England and on our website. Requirements. The report details the 28 deaths that were sadly reported to the programme this year and also the outcome of 29 reviews. Slight anomaly with the numbers due to just some deaths are reported from 1 year into another year at the beginning of the year, so they don't always completely marry up. This is an increase in the number of reports reporting into the programme. It's not statutory, and it comes from a variety of people, including health and social care workers, care agencies, places where people live, families, GPs, and others. So driving up those number of reports is really important so we get the best information we can in which to do the quality improvement work that's required across the system. Despite that, we do remain to have really small numbers, and so this goes into an annual report which is nationwide, which the University of Bristol coordinates, and that was not published at the time of writing that paper. This paper, however, has been since. And our median age of death, 59 years, is with our small numbers, is fairly close to the national one of 62. But that remains 19 years younger than the population of this age. So really, nationally, we are still working with very similar themes and trends around the reasons that this programme exists in the first place. So things like aspiration pneumonia haven't changed at the very first time that these were looked into, and continues to be an area that we continue to work with and have had particularly progress around care out of hospital.
I would say, more than in hospital, because it's often about the way people are living their lives in residential care and supported living, and in how they socialise and work together. So I think there's some, some points from the report that people might find interesting. One of the things that we have acted on this year, and worked with primary care colleagues again really hard on, is increasing the number of 14-year-olds and above that have getting an annual health check. That is crucially important because often people with LD and A seek help early, as others may do, or recognise those symptoms early. So having an annual health check is really important, and I'm really pleased to say that that's our best we've ever achieved, over 80% last year. So and that was a real big improvement for the system as well. So really huge thanks on that one. But there is inevitably more we can do, so please do.
Thanks. So,
just
Picking up the aspirational pneumonia, I thought you were quite right. Is a theme that's picked up nationally. I'm just wondering, we should be complacent about that, because quite often it is linked to failures in care, so diagnostic overshadowing, not providing enough support around eating, care, making us true reasonable adjustments. And obviously we know there are issues with workforce challenges around dietetic, LD nursing, all those issues. I'm just wondering, is there anything that we are specifically doing as an action, as providers and across the system around that? Because I thought we should be complacent with the national issue. What more can we do here, particularly now that we've got disability practice things that we're all in each provider and general practice? Yeah, thank you. So the antibiotic adjustment flag is required by December. There's a working group as part of the process to get that implemented, and that will say, we have all adopted on training in the last few years. We are becoming more aware of the needs of people with LD&A, but aspiration pneumonia specific needs as well, to make sure that people can swallow correctly and that their respiratory care is good. And I think you raised a really good point about what else can we do across health and social care in this area. And I totally take that challenge beyond education, raising awareness. What else?
I'm wondering whether there could be a specific action on that point in terms of, so we're receiving the report, perhaps to come back to the next meeting so that we're a bit further on reflection with our system partners to do a sort of practical intervention that might ensure that there would be improvements around aspiration. Anything else? Can we approve the report? Thanks so much. We're moving on now to a range of reports from committees. I suggest that as we go through, we take them as read. I'll come to the committee chairs, if there in particular you wish to point out, and then we'll move to the recommendation for our school. All the papers have been read. So first of all, show the System Quality Performance Committee.
So just a couple of points I would raise for the board. There's still concern around diabetes, what's happening, and the fact we outliers on indicators, which are really important for this. So that was very concerned moving forward. TB is known to be a fragile service. The positive news there is that the business case has been approved through the ICB, and understand it's well underway now in terms of the improvement, and so that work can be taken forward in terms of providing the basic patient service there. Positive actually, so in terms of it's no about staff really, but the work's been undertaken. Very brief, in terms of the 8-hour uploads, how we numbers have down significantly. And I believe in August it's 7 from what's 122, 132 in December 24. So I think that needs to be just noted really. However, what I would say, if you're expecting to say that is still 7 are waiting over 8 hours.
and there's a level of assurance that harm reviews are taking place for those. So well done to the team for that. And then just finally, we have got the terms of reference in the appendices for the teams.
Any questions or comments? Can we note the report and approve the terms of reference? Thank you much. Moving on then to the system finance schedule. They've not here, but any questions or comments on the reports? Yes.
I think that the integrated performance report gives a more up-to-date view, and it's just a similar request for agreement of the terms of reference.
See, let's approve the terms of reference. Thank you. Stacey's not here for the particularly the people culturally included committee today. Any comments or observations? So we note the report and approve the terms of reference. Trevor, remuneration reports?
No, nothing to add, thanks.
Thank you. Can we then note the report and approve the terms of reference? So I can start that and then audit committee report. Trevor, this is you this time, I think.
Okay. Yeah, again, nothing really other, obviously, external audits overtaken by what's happened since then in terms of everything gone through with a clean bill of health, which everybody should be commended on. Internal reports, like a lot of things within the ICB over the last couple of years, really a general uptick in terms of the performance and the responsiveness to recommendations and things by the internal auditors. So everything moving on quite well.
Any comments? No, then we are receiving the content of the report, the Freedom to Speak Up annual report. Just to note that Cheryl's kindly agreed to be the lead head on Freedom to Speak Up. So thank you very much.
What are you going to say?
You did agree. And note the committee annual report and then the terms of reference. The Strategic Commission Productivity Committee Chair's report, that's my report. Again, just there's no change to term reference. Everything usefully established, but any answer any question on that report. And then the System Transformation Digital Chair's report.
Nothing to add to that one. We had our latest meeting this morning. We agreed for next time. I think we need to get our head around more of a provider collaborative transformation. Uber reliance on CB cluster. So it just
so again, I don't know, it'll be fed back through to us over when you're ready for that. Let report and so and then the System Strategy Prevention Committee. Kathy?
So, Chair, just to say that there's now a real focus on prevention with all the strategies now, and we welcome that. And we're working really well with the local authorities and DPHs, and we're now sharing our agenda and minutes, and the health and wellbeing board is with us as well. So we've really joined up now. And finally, TOR to be approved, please.
Thank you very much. So a range of recommendations outlined in the report, including the updated terms of reference. That's all of the committee reports. A quick review of the meeting. So first of all, thank you for making it a pleasant experience for me as your chair for the first meeting. Today, particularly what's tremendously, I understand the reason why we just need to reflect in terms of a manageable amount of paper in a position to digest. Obviously, quite important that I don't think the resident story is really impactful and very positive. Something that I think maintain. Any other sort of reflections for people in terms of the meeting?
I think you mentioned it a couple of times in terms of some of the really meaty topics, which have been really valuable, have some good quality discussions, using our community structures and or other forums. It's important, especially in the public, to have, to do the correct things before. And actually, with some of these, it's a bit more with the correct or more where it has everybody with my identifying something that things work well.
Any risks that we have flagged in the I don't think so. This comes to my attention. Okay. And I've not been notified of any other business. Is there anyone who's got any questions?
I'm not sure if there's a chief exec report. Also, whilst we recognise Deborah's last meeting in public, was also Ian's last meeting in public, and so it'd be appropriate for me to say thank you. Appreciate your work and effort. Undoubtedly made a positive contribution, and the providers continually talking in terms of that engagement way of being positive. So we'll continue to work with you for the next 6, 7, 8 weeks. There won't be another public board meeting.
Thank you. The reduced number of in on the board by. Thank you very much. The next public meeting is going to be on Wednesday, the 26th of November, 2 o'clock. Thank you very much. Good. Take care now.